So I just start with a brief introduction. I'm happy to introduce Dr. Krishnaveni for the Insight Thursdays hosted by the PMU today. So today the topic of the presentation is data harmonization and standardization in biomedical research, perspectives from the cohort study. So so this seminar is today hosted by IPH along with PHFI, Center for Development and Life Course Research, CDLR. So I also want to acknowledge my thanks to Dr. Debrati and Eunice for helping me coordinate and having the session today with Dr. Krishnaveni. So to introduce, Dr. Krishnaveni is a clinician turned epidemiologist, currently working as a senior scientist at Holsworth Memorial Hospital in Mysore. She's been involved for over 25 years in epidemiological studies on development origin of health diseases in Mysore. The main objective of these studies is to understand an influence of maternal and offspring life course factors on development on adult non-communicable disease. She's also a recipient of DBT Wellcome Trust Intermediate Fellowship. She's also a co-PI in Healthy Life Trajectories Initiative, an international consortium comprising of the harmonized trial based on development origins of health and disease principles. We are happy to have you here, ma'am. I also want to add in that this is the first of its kind that we are starting. Moving forward, in collaboration with IIPH and School of Advanced Studies, we would bring out a webinar series slowly. So this is in a very initial stage. So we will slowly we are in the planning stage. Slowly, as and when it progresses, we'll keep you updated on that.
Yeah.
Miss, would you like to add on anything if I may have missed?
No, and I think you have said enough, more than enough. So
thank you, ma'am.
I think thank you very much for that kind introduction, and also for inviting me to share my slides in this platform for the the first, as of the first speaker in the new initiative that you are starting, and all the best for your initiative. So thank you, Debarati, who actually was the first to invite me, and also the organizers IPH and IIPH for giving me this opportunity. To be honest, this is also the first time for me to present this kind of presentation. It's actually a refreshing first experience, because I always present data from my studies. So bear with me, if I don't, answer all your questions and doubts. I mean, if I think about it, so this is not rocket science. You are all active researchers, and if you sit for a while and reflect, you can compile the points that I present here today. I'm just doing the job for you, but there's nothing new that you can find here. So I hope I'm audible to all.
Yes.
Yeah, I might cough a bit in the middle, so please bear with me. So harmonization, harmonizing studies and harmonizing data is not a new thing. It's been happening for many years. We see all the meta-analysis papers, and we look at all this pooled analysis for growth standards, for different public health messages, comparative analysis. For some reason, the term harmonization itself is quite new, I think. So wherever you see now, people talking about harmonizing studies, harmonizing data. To be honest, I hadn't, I myself have been involved in a couple of harmonized projects, but till recently, till being part of one of the largest harmonized studies, quite recently, I had never, thought of this exercise as harmonizing. This term itself is new to me. So I looked up the definition for this and the internet, and this is the definition I thought I like the most. So it says harmonization refers to the efforts that provide comparability of data sets from heterogeneous source to allow for combining, pooling, or integrating them in a coherent way. So 2 points that are most important in harmonization is, identifying heterogeneous sources and making them as comparable as possible. So both comparability and heterogeneity, according to me, are quite broad, concepts. Comparability can be as precise as you require. For some clinical parameters, for clinical messages, you need very precise measurements, very precise, harmonization. Whereas there are such broad and abstract concepts like, socio-economic position or, psychological aspects or cognitive function. So where it is not even possible to have such a precise comparability. So that needs to be uh, kept in mind. Again, heterogeneity. So heterogeneity can be in any way. It may be different geographical, places, different type of ethnicity, different socioeconomic uh, positions, or within a population. It may be gender differences, age differences. So all these things, it depends on the research question and the how much comparability and compatibility the research objective warrants. So I try to put for in front of you a few points that might help you in going forward doing some harmonized studies or harmonized analysis. So my qualification for doing so, for being the person to tell you that you have to do this, I mean, Debarati thinks I'm qualified enough, but if I think about it, I think it is because of this study, Healthy Life Trajectories Initiative, which is one of the largest globally harmonized studies, ongoing studies, intervention studies, a longitudinal study that's been progressing across 4 countries, India, Canada, South Africa, and China. So it has several objectives related to early life nutrition and early life exposures and late life NCD development. However, one of the main objectives of the study itself is data harmonization and comparison across countries. So the study, it's from the inception stage itself, from the identification of research objective itself, harmonization process started. I'm happy to say that I have been involved in the study since the inception, and I have been the representative of India for harmonization exercise. So I'll try to, present some points relevant to data harmonization in large studies, large cohort studies, based on my experiences of being in that working group of healthy harmonization. So, I mean, if you look at the countries that are involved here, they're as disparate as, highly urban, developed Canada to, resource poor, undernourished population in tribal Hardis in Mysore in India. So, I mean, there cannot be a good example of the efforts that go into harmonizing data in biomedical research in heterogeneous populations. So just to give an idea of the extent of efforts gone into harmonizing healthy data. So healthy study is basically a multifaceted complex intervention study where the intervention starts preconceptionally, continues through pregnancy, and also in early postnatal life. And the main outcome is the adiposity of the child at 5 years of age. So the recruitment will happen during preconception. Young women, married women will be recruited, and they will be followed through, preconceptional period, pregnancy, and the first outcome won't come till 5 years of till the child becomes 5 years of age. So it is a very long study. The first outcome itself won't come, won't be presented for another 5 years at least, as far as we know, even and more than that. But even more, daunting is the harmonization effort that self took place. When this study has been initiated by the WHO with Canadian Institute of Health Research. So once the study participants, the participating countries have been selected and identified, the harmonization has been in place since starting from what objectives to study, what outcomes to present, what would be the primary outcome, what would be the secondary outcome, what would be the intervention package. So every aspect of it has been harmonized. I just talk about data harmonization, not about other aspects. For example, intervention is also harmonized, data analysis harmonized, process evaluation is harmonized. So I talk about the data harmonization aspect here. So harmonization effort started in 2017, nearly 9 years back. So intensive harmonization meetings happened from 2017 to 21, almost 5 years. So every 15 days to 1 month, there was a working group meeting to identify harmonized variables. The meetings are still continuing in a low-key manner. This is just, the routine variables. There are separate working groups working on specific aspects such as neurodevelopment or, biosamples, data analysis, etc. So these meetings were attended by a working group comprised of senior researchers from each country. These researchers were able to, they had the full knowledge of the study and they were able to take executive decisions in the meeting without, going back to the other investigators. So quite senior level researchers and project managers and data managers. And the whole process itself was moderated and is being moderated by specialists in harmonization and data management. We were moderated by a research organization called Maelstrom Research Organization. So if you just look at it, the amount of work, the amount of, money, the amount of person hours, all these efforts went into this is enormous for a study. So this, begs the question as to why, what was the necessity for doing such a labor-intensive, exercise for this particular study? What would this achieve? So as far as, the health is concerned, I think the most, important and the most useful outcome of this harmonization is that the study can give a robust message, global message for public health, which can directly feed into public health policies. Since we are doing this study in a harmonized manner in 4 countries, which are at different stages of transition, so it is, possible to pool the data, or, parallelly analyze the data to look at the commonalities and differences in the associations. So since we are all using standardized methodology, we can look at how they are all, common, what common message can be given to public health policies. At the same time, the beauty of the study is that we will also be able to look at the unique aspects of each, study setting, what works differently, why something is not common, how the message or the policy should be tailored to address those nuances in these different populations is again something that can be addressed because we are using common methodology but seeing different associations. So other advantages as far as the pooled and harmonization of data is concerned is it allows to enhance the power by doing pooled analysis. So the power to look at associations which are new associations which are for rarer outcomes, which may not be, feasible in smaller studies and done at different places using different methodologies. And finally, as I said, doing multiple studies, each doing different, using different methods and different protocols may not be an efficient use of resource, because finally you will be duplicating study without adding extra advantage, in terms of pooled analysis or increasing the power. So harmonizing data, which has come up in a big way in these days, these few past years, is an important new initiative in many studies and many research settings. I think it is something that is going to stay and probably the way forward in the biomedical research area. So to give a bit of details about harmonization. So harmonization can be prospective. I just talked about healthy, where the harmonization process started as soon as the study was, idea was conceived. So every aspect of the study will be done prospectively. There is no dependency on any retrospective data collection. Whereas retrospective harmonization mostly depends on already collected data. I mean, there are so many studies already, smaller studies, although, as I said, a number of meta-analysis, you may have read several of them or have done yourself. And there are all these growth standards such as intergrowth. So all these things, not intergrowth, that is prospective, but there are, different pooled analysis, which gives single common outcome, which helps in coming up with newer research or newer public health messages. All these are retrospective harmonization, where data has already been collected and the researchers leverage on that to come up with answer newer research questions. And in the current context, I think Karnataka Birth Cohorts Consortium itself is proposes to do retrospective data collection going forward to understand and explore associations related to life course questions. So let us just look at prospective harmonization first. As you all understand, like any other study or any other approach, any other aspect of biomedical research, doing prospective harmonization is the most ideal way to do it. So prospective harmonization may be very specific, small study, a small cross-sectional study, only looking at specific aims and a few relevant variables, which is relatively easy to do. I have given an example of Intergrowth 21st, a project run by the Oxford Maternal and Perinatal Health Unit in collaboration with the Melinda and Bill Gates Foundation to develop internationally acceptable growth standards from birth to 2 years. So the objective is very specific, and it requires data collected in multiple sites all over the world, mainly related to growth and nutritional status from first 2 years of life. So as opposed to cross-sectional studies like, Intergrowth 21st, Healthy is a longitudinal study with broad objectives. So as I said, the study starts with young women who are married but not yet pregnant. But, the first phase of the study itself continues till that woman's child becomes 5 years of age. So it's a quite long study and has multiple time points of data collection, as you can see here, from adolescent mothers to the offspring childhood. So it has very broad overarching aims. So it is an integrated intervention that looks at the preconceptionally started intervention, whether it will optimize infant and child growth, reduce the burden of NCDs, and tackle intergenerational transmission. So there, as you can look at the objectives, you can see it can be built in several ways in analysis. So you can't just say, you have to look at the first, object. You only have to collect these variables. It is not possible. The opportunities are, numerous. Range is numerous. At the same time, difficulty is also quite high in this context. So that is the gate to give you an example of the prospective harmonization. So let us look at what are the steps that are involved in the harmonization process in the prospective studies. So as you know, in any project, the first step is to formulate the research objectives. Like any research question, any research objectives, it stems from the current need, the local need, the most contemporaneous aspect of health, which requires this objective to be studied. For example, if you look at healthy, it looks at the long-term, implications of improving maternal nutrition and overall well-being on offspring health, as well as reducing NCD development in the offspring. So once the research objective is identified, selecting suitable populations or research groups, usually in studies like intergrowth, there is a set protocol, what countries are required, what different kind of populations are suitable. Healthy went through a rigorous application process. The applications from all over the world were reviewed, and the Mysore team was selected for India. So in Healthy, the 4 countries are at a different stages of transition, which gives an edge to answer these questions for different population context. So once the studies are and the research groups and populations are identified, the harmonization process begins. So the first step in harmonization is to define what domains to be, assessed to answer the research objectives. So, and, as a group, different studies, participants come together to identify and agree on not only the domains that need to be studied, but what information need to be collected for that particular domain. For example, if you are measuring, if you want to look at the dietary status and dietary intake of a woman on the health of her offspring at birth, so what diet, that you need to collect dietary information, but harmonizing what dietary information need to be collected is another, another problem, because there are so many dietary tools are available, so many dietary aspects can be studied. So identifying the right variable for that and right information to be collected would be a challenge and requires much discussion and understanding. Once the core information that need to be collected, so for example, for dietary information, you may decide on food frequency questionnaire. For body composition, you may decide on, we want to measure body fat percent, not BMI or not base circumference. We want to measure body fat mass, fat percentage, and lean mass. So that is the first stage of harmonization and agreeing. The next step is identifying and standardizing tools to measure this particular information that is required to answer our objectives. This is one of the trickiest aspects, especially if the participating groups are as heterogeneous as one in the Healthy. As I said, there are urban groups, there are, urban development, highly developed urban groups, urban slum groups, there are rural, impoverished rural groups. So identifying a single tool that measures the aspects that we require in a very valid manner is really a challenge. So a lot, in our own study, in our own efforts, a lot of time went into, looking at different tools, different questionnaires, that are relevant for all the, 4 countries. The questionnaires that are relevant for, South Africa may not be relevant for India, somewhere where they're measuring partner abuse, or, single, plights of single mom may not be applicable here. So whereas where we are looking at some of the dietary issues here may not be applicable in countries which have a set pattern of dietary habits. So identifying tools which are relevant for all the groups, not only relevant, but validated for different groups, is a challenge. And that is one of the most time consuming aspects of prospective harmonization. So finally, once we identify the standardized tools and methodology for each domain and information that need to be collected, so next we move on to looking at the variables that can be harmonized. As you know, each tool will give multiple variables. If you go for a questionnaire that measures anxiety, you may have 50 items on that. Some may be more relevant, some may not be. So the next step in the harmonization, in the prospective harmonization, was to look at each variable and see whether that can be harmonized in our setting. So for example, there was a questionnaire on sleep habits of children. So the questions that, wanted to know whether the child sometimes slept with the parents, or, didn't want to sleep alone. See, some of these, questions are irrelevant in our settings where the children always slept with one of the elders. So there were variables which we could not harmonize. Maybe there are variables on substance abuse which are too sensitive to ask. So the working group has to identify what variables finally can be harmonized in that particular context, and include that in the final set of core variables. And finally, once the core variables are identified, the final harmonization would be around data analysis plan. So what statistical methods, and what are all the different steps of data analysis that we need to do? If it is an intervention study, when do we unblind? When do we analyze different time points of outcomes? And what test do we use? So these are all the data analysis plan. Again, harmonizing this would give extra strength to the study and the final outcome that we are presenting. So just to give a brief, introduction to healthy life trajectory study, just to show the extent of the data that is being collected. As I said, it is a multifaceted intervention study. So there are several objectives for this. I'm not going to that, but in addition to, harmonized intervention and data collection, we also plan to, propose to establish a biorepository for future mechanistic study. So there needs to, there is there is an extensive biosample collection, which itself, methodology for which itself needs harmonizing. So we have different interventions around nutrition, hygiene, mental health, and exposure to pollution, both at the preconceptional as well as pregnancy stages. In pregnancy and postnatal stages, we also start intervention around parenting and parent-child attachment, and also learning. Interventions to improve child development. So the measurements, we have a number of measurements: physical, socio-demographic, nutritional, and clinical, mental health, various measurements at different time points: preconception, pregnancy, postnatal period. And that's just for the mother. And then we have a number of domains to be measured for the offspring itself, at birth and infancy at regular time points, and finally during childhood and at 5 years of age, where we are measuring, our final outcome. So if you look at the range of the information that need to be collected and the number of variables that each information generates, you can imagine the mammoth task that is involved in harmonizing such a study. So this is the final outcome as harmonized by the groups is the fat mass index at 5 years, again because different settings, for example BMI, which is relevant in Western population, which is popular, may not be applicable in Indian populations where the fat mass is relatively high for a given BMI here. So all these things also needed discussing and arriving at a consensus. So finally, different biorepository biosamples collected needed standardizing SOPs and storage, and also what analysis need to be done going forward. So with such an array of variables being collected in the study, harmonization itself was a project in itself, and this is the paper that came out of it. So the harmonization, as I said, it took almost 5 years, and initially we decided on the time points that where we needed to collect these variables. So we identified 10 time points starting from preconception of the mothers to the childhood, till the 5 years of the child. So as you know, since the population is so heterogeneous, it is not always possible for all groups to agree on all time points or all aspects of harmonization. So as you can see, some countries decided they can't do certain follow-ups. So in India, we tried to do at least weight in all follow-up time points for the child. So understanding these difficulties with different groups led us to come to a decision that a harmonization will be considered even if 3 out of 4 countries agree to harmonize their variables or measurements at that time point. So these are the steps taken by HELTI. So 10 common data collection points, common set of protocols and variables, consensus on core topics, which is similar to what we looked at for the prospective studies at large. So consensus on core variables for each topic. And once the working group reached a consensus on core variables, the working group members went back to their local teams and validated their decisions with the local investigators and the local research team, so that these variables are relevant and can be collected in the local population. So as I said, so any variable that can be harmonized in 3 participating countries was included in the course data set. So this is the final, the outcome of harmonization. So these are all the domains that were harmonized, and the y-axis is the number of variables in each domain. So more than 1,000 variables have been harmonized in the first phase of the harmonizing effort. So which is published, and if anyone is interested, they can have a look at the paper. So there was, this is again, some problems that may be faced in other studies. Some constructs are asked in a different way in different, study settings. However, it was possible to derive a single, variable out of these different information. So such variables were, such tools were included in the harmonized data set. So this is just an example of how we carried out the harmonization tasks. So like, X's are where everyone is agreed, and, different letters denote where only different countries do that particular assay. So, I mean, if you look at it, it is such a huge task. Of course, it's a huge study, so which requires that kind of exercise. But in any type of study, prospective harmonization is a huge effort. However, it also has huge benefits. As I already said, it gives high quality of data and high level of comparability. Pooling and giving public health message is straightforward. And if you have identified studies at different settings and from different population context, it can be generalizable for a wide population. So it also increases statistical power, as I already mentioned. So analysis and pooling will be smooth. There is no need to break our head about whether this variable will fit or not. And once we start the harmonization in the first phase, for example, in healthy up to 5 years, since these groups have already been harmonized, it is easy to harmonize any future studies in subsequent follow-ups. And as we have already seen in healthy, it also facilitates different collaborations with different groups for data sharing and embed additional studies in the available resources and available data and the ongoing study. However, as you can identify, there are also challenges. The most obvious one is it is expensive, it is labor intensive, it is time consuming. And also, when the populations are so different, it is very difficult to identify valid standard methods, and it may not be, we may not be able to harmonize. For examples, we could not find any valid relevant common tool for measuring dietary intake in these countries. Sometimes common protocols may not be practical in different settings, and we may need to use study specific tools for these constructs. And since we have already built our study on a particular type of harmonizing and a particular harmonizing the methodology, see if in future if there is any new technique that is available for our country which is more valid and may give a better outcome, we may be limited in terms of flexibility. If we want to continue the harmonization, we may have to continue as with other countries, so that limits future flexibility. So now let us look at retrospective harmonization. I mean, as the term describes, this is built on data that has already been collected in different studies in different populations. So this set of these steps for harmonizing retrospective data has been extracted from the publication that you can see here. The Maelstrom is a research organization that specializes in harmonization. As the paper outlines, so defining the research question and identifying the studies is similar to the prospective harmonization. So once we identify our objectives and studies that are conform to our need to answer our objectives, the next step is to look at the variables that are available and evaluate the harmonization potential. Then processing the available variables into a data set, estimating its quality, and finally data analysis. So if we look at these steps one by one, defining the research question and objective, it is straightforward. So the study may propose to look at a single association. For example, if it wants to look at the association with birth size and future development of blood pressure, it can look at in adult blood pressure. So the investigators may want to look at all the studies that have presented data on the association between birth size and future development of blood pressure. So it's very straightforward, and there may be, very specific, so relatively easier to address this because you only have so many variables to harmonize. However, studies that look at an overarching objective may like to harmonize as many variables as possible within the available studies, identified studies, so that there is a greater scope for doing different analytical studies and looking at different associations under the overarching objective. I think Karnataka Birth Cohorts Consortium is proposing to do one such harmonization where different birth cohorts can be harmonized for the available variables to look at the life course aspects of developing future diseases, if I remember correctly. So identifying the research question as well as identifying relevant studies requires extensive literature review. You need to identify studies, you need to approach the study investigators. So this is the most common approach for doing retrospective harmonization. However, there may be groups which which in a consortium which have been ongoing associations. They might identify cohorts which are similar to characteristics in their own for their own study, and may approach them to do harmonization either for a specific question or for a larger future project. For example, SNEHA is a consortium of studies on developmental origins of health and disease in India, for which Mysore is a partner of. So those studies conduct standalone in these different cohorts, and there are instances where two or more cohorts come together. They have come together to do a pooled analysis of a particular interesting research question which is common to both. So however, before you formulate the question and identify the study partner, you should be clear in what population is suitable for your for addressing your study question, what setting is, and what exposures and outcome variables you need. So that narrows down the possible studies. So it minimizes wasted effort. So once the study partners and participants have been identified and approached and agreed to be partners, the most important next step is evaluating the harmonization potential of the variables. So most of the studies, I think almost all the studies have a dictionary of their data, dictionary of the variables of their data. So which may be called data dictionary or variable mapping, which gives, which lists the number of all the variables, the names as it is in their data set, and give description of what this variable means. So not only their label, also how they are measured. Okay, so here it is last menstrual period, gestational age based on last menstrual period. So this particular variable gives that in weeks. This particular variable gives that in days. So giving every detail of that particular variable helps harmonization efforts, to continue smoothly without having to go back and forth with the data manager. So this is one of a screenshot from the data dictionary of the Mysore Parthenon study, which I am leading. So this is another example from the same data set. So it is also important to identify, when that particular measurement has been done, and what is the unit of measurement. So for example, here birth weight is in kg, but sometimes, it may be given in grams. So when you combine data which has different units, it will be difficult to interpret, and it creates confusion, and again, it increases time taken and also creates chaos. So it's at this stage itself, the first step is to share the data dictionary, which has every detail about every variable. Once the data dictionary is available, so the next step is a very, it is, equivalent to the harmonization efforts that went into healthy. So it is the stage where the senior researchers need to come together at, regular intervals to look at each variable and each domain and identify which variable can be harmonized, which variable it is possible to directly harmonized, which variable needs some, thought, some discussion, and some conversion. So a working group may be created, and, a moderator who has sufficient knowledge about data management and data processing and analysis would be a great asset in doing that, because they can always help in the working group coming to a decision. So the participants for the working group from different studies, different individual studies that come together for harmonization. So ideally they should be fairly senior, who have a full knowledge of their data set, how it's measured, when it's measured, what it means, and also should be in a position to take a decision soon, fairly quickly within the meeting, or at least within next 1 or 2 meetings. So it's very important to identify such personnel. It is not like, so it's a job for research assistant, let them go and do. No, it won't help it, because, it just wastes the time, and sometimes it may lead to erroneous harmonization, harmonized data. So please be aware that, this is the most important step of harmonizing your studies. So it requires people who know the study in and out, and who should be in a position to say for sure that, yes, this can be harmonized, and I'm confident about that. So the harmonization can be for different aspects. The first thing is identifying what variables you require for you to answer your objective, and second, to see what method has been used to derive that particular variable. So for example, some measurements are straightforward. Weight, weighing scale, so it just gives a number and you write it. There is no ambiguity in either weight or height or blood sugar. But some measurements like body fat, they may have different ways of defining. Some studies say BMI is their body fat measurement. Some may use fat percentage, either using bioimpedance or DEXA. Some may use 2 compartments, some use 4 compartment medal, some use skin folds, some just take weight as a proxy for fat. So when you identify the study, it appears as though they have these measurements, these domains measured, but whether that technique that they used is compatible with the study objective is something that should be determined by the working group. So you identify what is relevant, whether these can be interchanged, even though the method used is different, whether that can be somehow pooled, that is the decision that you can take. Secondly, what time point do we need? If we are measuring, if we are looking at gestational weight gain as an outcome, what should be the pre-pregnancy weight? Is it before pregnancy or early pregnancy? If it is before pregnancy, how far before? If it is early pregnancy, is it first trimester, or how far into second trimester? What should be the second measurement, whether it is close to delivery or any time in third trimester, or any one measurement after the first trimester? So these are all the decisions that needs intensive discussion and agreeing upon. Finally, looking at whether the tools used are validated and well calibrated and the methods are standardized to have confidence in the validity of data for different constructs. But at the end of the day, it is a fine balance between how precise your variable needs to be and how, feasible that is given the heterogeneity of the participating studies. So this is a decision that needs to be made by the participating investigators. This is at the discretion based on what the study objective requires, how precise the variable needs to be for the study objective. Whatever the decision is taken, be aware that that decision has to be made a priori and it should be documented, and as much as possible, that decision is followed through the whole project. So once sorry, Rashmi, I'll take a few more minutes. Once the harmonization potential has been evaluated, now you assess the data for, first you process the data to make them into common variables, comparable variables. Because some may have measured weight as continuous variables, some may have presented them as categories like underweight, overweight, etc. So again, the processing stage, you can convert continuous variables into categories so that as many studies as possible can be included in the analysis. For some constructs, it is difficult to get a common score. For example, different cognitive tests may be used in different study settings. Different, socioeconomic tools may have been used. In those instances, you can see whether these constructs can in somehow be ranked within the population and use those ranks to compare across different cohorts, so that you can still harmonize these disparate data. And next, you need to decide whether you can get individual level data or just the summary data, and your analysis, conforms to that accessibility. And finally, look at the quality of the data. You can't assess the quality of assessment itself because the measurement has already been done. You can only look at whether the tools used are valid and standardized, and whether regular consistency checks have been done for the measurers like intra-observer, inter-observer variation studies, etc., calibration of tools. With the data itself, the data manager can look at the pool data from, the data sets from different studies to see whether there is a consistency in recording data, whether the range given is plausible, any outliers, and what is the extent of missing data. All these steps help to assess the quality of the harmonized data. So, you can keep on talking. Once you start the process, you will understand that there will be more problems and more, issues that come up, and you will find solution as and when. But these are the common points that one need to be kept in mind, to keep in mind while doing retrospective harmonization. So with all the loopholes and all the shortcomings, still retrospective harmonization is one of the most preferred harmonization methods because it's quicker, it's cheaper, it leverages on the existing data, and easy to approach multiple sites and collect data from multiple studies. And in addition, any past exposure and outcomes available within that particular study setting can also be, leveraged to give additional insights into your research question. So definitely retrospective harmonization is one of the most preferred harmonization methods. And as you have heard, that it has its own challenges, and the first and the most important one is accessibility issues. Some data may not be, some researchers may not be willing to harmonize or provide data for various issues, either because of local ethical committee constraints or local country level legal guidelines, etc. So data integration, as you know, is as you have seen, is not straightforward. Different methods require some discussing and reflecting whether it can be harmonized or not. And data assessment quality is not, we only see the data, we don't know how the data has been assessed, if there is no clear documentation in that particular study setting. So these are the things that again to be considered while doing harmonization. Just a few slides on how the data can be analyzed using harmonized data set. There are three ways of analyzing: co-analysis, pooled or integrated analysis, or federated data analysis. Usually co-analysis and pooled data analysis go together, and people who do meta-analysis do both of these in most circumstances. So pooled co-analysis is also called, can be a parallel analysis, where though there are more than one participating study, this data is analyzed specific to each study. And when you present the data, you compare and contrast the outcomes from these different individual level analysis. This is one such study where the data has been combined from Mumbai Maternal Nutritional Project and a similar study in the Gambia, looking at the effect of DNA methylation on cardiometabolic risk factors. And doing the individual study showed that though there is an association between DNA methylation and cardiometabolic risk factors in both sides, the cardiometabolic factors themselves are different. It is blood pressure in Gambia, whereas insulin sensitivity in Mumbai. But when they did the pooled analysis, there was an entirely different association. But the association was there in all aspects. This is another example. Another way of analyzing data, which is pooled analysis. So most commonly seen in meta-analysis, where a particular association is tested from multiple sites, data from all sites pooled to give a single odds ratio or an effect size, which helps to understand the robustness of the association. For example, here this is from a paper that looks at the association of preterm birth and lower, small for gestational age birth with undernourishment in the first 2 years of life. So again, as you see, there is an individual level co-analysis data as well as a pooled analysis data, which is the diamond here. So finally, the federated analysis is something which is quite popular now, especially if the harmonization is across different countries, because there are guidelines and restrictions in some countries with sharing data outside the country. So federated analysis takes care of this. So there will be a centralized analysis, but the individual level data remains on the local servers of the country itself. The group can, do the analysis through their server, but they can't extract the participant level data. They can only extract the summary level data. So this is the data analysis plan, proposed for the healthy study, and which is facilitated by the software RedCap, which is used for data capture in all the 4 participating countries. So yeah, I think that's the end of my presentation. Just to conclude, harmonize. It seems that harmonized way of doing studies is the way forward now. It is an important resource now because it gives a global, public health messages which are largely applicable in different settings and generalizable. but it requires rigorous and standardized efforts in the participating studies. Otherwise, such an effort would be futile. So that needs to be kept in mind. Thank you, everyone. Thanks very much for giving me this opportunity.